So here's real case. Unfortunately, it's my case. This is a 54-year-old physician's assistant who tore his rotator cuff probably 2 years before, and he's just managed. He was trying to get by and not have surgery. He has reasonable range of motion, but now finally he's breaking down. He's got pain. He's got weakness. He can no longer get back to doing his job. So here's just sort of a glimpse of all of his images. Little bit of, well, again, Goose, you got 35 seconds. Just give me what you got. What do you see quickly, and what are you gonna offer this guy? Don't ask for more images or you get deleted.
Yeah, he's got it's like around the horn on ESPN. Yeah, he's got a high riding humeral head. It looks like he's got good muscle quality, but he's got a massive tear that you defined as irreparable. So for me, I want to make sure that I can get that head down with like that it's not stuck up in the with that narrow acromial-humeral interval. And if I can, I'm going to plan for an SCR and biceps tendinosus with a partial cuff repair.
SCR. Raff, is you going to do a BAR, acromiotubero-fendlino, what?
I'm going to do SCR as well.
Got it. Jay, he's got good muscle belly. What are you going to do?
Do I get any pearls on his exam, Paul?
Yeah, he's got it. Thank you. It's a good question. It's actually a very relevant question. 155 degrees of forward flexion and no lag sign.
Okay. So I think,
Let me ask you a question, Jay. Is that what you wanted? And what other pearls would you want? What's relevant in your decision-making?
Well, is the subscap intact? Is the biceps a pain generator? Making sure he preserves his overhead motion and how much external rotation weakness he has. So the other things that are prudent are who he is, what he does for a living, what his demands are, because that will factor in. I mean, obviously a banker versus a concrete worker, finisher, I'm going to have different treatment algorithms. So if this is a normal, regular guy, white collar, 54-year-old, as Grant mentioned, there's some migration, but there's not Hamada 3 changes. So he's got preserved motion. If his subscap's intact, I would go in and attempt a partial repair. If maybe I broke a rule there, sorry. So my backup plan would probably be an SCR in this case, or a lower trap transfer, depending on how weak he was with external rotation. This is the kind of case where I think you can get a partial repair and a good outcome. His infraspinatus, those aren't T1 images, but his infraspinatus muscle doesn't look terrible. So the injury is 2 years old and you have a lot of retraction, so you may not be able to pull the supra over, but that's always an intraoperative decision for me. So I would attempt repair. I'm breaking your rule, and my backup would be an SCR or a trap transfer, depending on how weak his external rotation was.
So I went in there and I said, look, you're gonna get a rotator cuff repair. You're gonna get a rotator cuff repair. And I think he went up to the University of Hartford, Connecticut, and you know what the doctor said? This is suspicious. The doctor in the University of Hartford, Connecticut says, if I do a rotator cuff before you actually need this reverse, you're going to do worse, because my friend Andy Jawa at the New England Shoulder and Elbow told me that, and I believe everything Andy Jawa says. So I said to the patient, well, the only good thing about this guy, Mazaka, is either his dad or his son, who you see below, who's actually a good lacrosse player. I don't have a question for you, Gus. I just want to show a picture and throw a dart at you. So he saw Gus. Gus said, you need a reverse. And he says, if you don't get a reverse, you're going to have a problem afterwards because they don't do as well. Gus, you got nothing to say. Suspicious. You see that word? Suspicious. So I got in there, and you know what, Jay, you were right. You taught me a lot of things over the years, and there was thick tendon, but I slowly mobilized it. I got a 3 anchors on one side. I got a bridge. The tissue actually was reasonable. And when you look on the MRI going back, it's thick tissue. It's not super thinned out tissue. So anyway, suspicious. I felt good about it. So as it turns out,
everything you say is suspicious.
Wait, you said it was definitely not repairable. That was like the number1 ground rule, and you just showed us that you repaired.
You don't ask questions. Did you see Rule 3? Rule 3 goes back to 1.
Pathologic liar.
So anyway, he gets in a motor vehicle accident, right, at 2 months post-op. And since he's a healthcare professional, he does me the favor of getting an MRI. So, you know, if he got in an accident, he comes to see me. I'm like, oh, don't worry, wait. But he comes with his MRI. And there's his MRI. Jojo, anything? What do you do now?
Yeah, it's retorn.
Yeah. Or is it retorn? Is it never healed?
Who knows?
Who knows? So the DUNCE cap, in case you don't know where the DUNCE cap comes from, John Duns Scotus, 1308, allowed for time for reflection and focus. It was a real thing. I put on my DUNCE cap. All right, so now what? Well, Gus, I made fun of you before. I didn't ask you to talk. I just gave a picture. So now we'll do it to Joe. Joe, you presented some exciting 2020 data. You can talk about this when we have it for us. Thanks. Good answer. Raff, Jay, Goose. What do I got here? Here he is, intraoperative. Here's the image. What I'm showing you or trying to show you is that his infraspinatus is on in the back and his supra is clinically off.
That's a cadaver. That's not a real patient.
Didn't you already see the slide before? Thanks for now.
No, I would have just done the SCR in the first place, like I told you to do, and I think he never healed the cuff. I think he probably tore the cuff by the time he got to the recovery room. Just happened to have an accident.
So because you teach residents and fellows, you can be pedantic. I just want to know what you do now.
SCR.
SCR now.
Yeah.
Jay, agree?
I would have injected and rehabbed him after the injury and talked about.
Can't do that. You broke the rule twice now.
And probably done a reverse.
Push mute on him. Push mute on. What you said? Reverse.
Yeah.
Okay. Goose.
So can you get a sense of how he was doing before the car wreck? Like, was he doing fine and then the car wreck and it fell off?
Honestly, you know, for a massive tear like that, for me, I'm not letting him go to rehab for 6 weeks. I'm keeping him in a sling the full 6 weeks. So it's disingenuous. He didn't have pain. His pain was significantly improved, but it's not like I had any sense that he had reasonable range of motion or anything like that. It was too early for me.
Well, if his pain was doing fine and he seemed to be progressing like a normal cuff rehab until the car wreck, you know, I consider going back in, repairing what you can repair and whatever you can't, SCR.